Welcome back. My guest is Dr. Neil Porter, a neurologist at the University of Maryland Medical Center who specializes in neuromuscular disorders. And Dr. Porter is also an assistant professor of neurology at the University of Maryland School of Medicine. And before the break, we asked our viewers to guess what the reason is for your foot to fall asleep. So could you explain what causes that?
Right. Usually this quote-unquote foot falling asleep is going to be some numbness or tingling in a foot, and that's going to be caused by usually prolonged pressure on a nerve. So if you're sitting a certain way and you're applying pressure to the nerve to that foot, after a while that nerve will start getting injured, and you will notice that by having these funny feelings being produced by that nerve.
Or is it the loss of sensation that sort of the communication down the nerve is being interrupted, so you don't feel anything?
Exactly, but the nerve then sends off signals that it's actually hurting, and then that signal is for you to actually change position and get off of that nerve, so that you don't actually cause permanent nerve damage to that nerve.
Right, it happens. I know when I sleep sometimes my arm falls asleep in the middle of the night, and I guess the best thing is just to sort of shake it and try to get the feeling back. Is that also restoring blood flow that might have been interrupted?
Yeah, I mean, people usually do shake it just as something to do, but usually it will come back by itself.
Oh, well, that's good to know. Well, one of the things that you treat people for muscle disorders, which we were talking about in the first part of the show, but there are nerve disorders that also cause pain, such as trigeminal neuralgia.
Exactly.
And isn't that pain in the face, like in the cheek?
Right. Yeah. Any nerve can be affected by a disorder that can cause pain. In the case of trigeminal neuralgia, it's specifically a nerve called the trigeminal nerve, and that's the nerve that supplies sensation to your face. As the name might imply with the tri, there's 3 branches to the trigeminal nerve, and those 3 branches supply the upper, middle, and lower portions of your face. And those nerves can be affected, any branch can be affected by trigeminal neuralgia, then producing pain. So
here we're seeing the blue, the yellow, and sort of the pink. Are all of those different parts to the trigeminal nerve?
Exactly. Those are those represent the 3 branches of the trigeminal nerve.
Huh. So are there some effective treatments for this?
There are actually a number of treatments for trigeminal neuralgia. The mainstay actually still is a medication, Tegretol or carbamazepine, and that's actually helpful in most cases. But there are alternative measures as well, meaning if medications don't work, there are other non-pharmacological measures that we can take.
Because trigeminal neuralgia causes what, like a shooting, sudden pain in the face?
Exactly. Trigeminal neuralgia, it causes a sudden, repeated, sharp pain along some part of the face, and that pain can be reported by patients as being either sharp, shooting, or shock-like, or some combination thereof. But it usually is fleeting, meaning that it's very sudden and then it comes and goes, but almost comes without warning in some situations.
Does it get worse with time?
In general, people can get treated and the response can be very good initially. Over time, from some of those people, the treatment does become less effective, so that for some group of patients, it does become worse over time.
And you mentioned a medicine that's pretty effective in controlling that. Does it mean that the person has to take that medicine all the time to prevent the pain from coming?
Exactly. That medication really needs to be taken on a continuous basis, because what you're trying to do is actually prevent the pain from coming on. So it's almost like a prophylaxis, actually.
Are there some side effects from the medicine?
Yeah, I mean, all medications have side effects, and the big problem with this mainstay, Tegretol, is that it can actually affect your blood counts, and it can make you feel somewhat funny or dizzy. I mean, those are very common side effects.
Oh my goodness. So what are some of the other treatments? You mentioned that there are some other therapies that are available for people who have trigeminal neuralgia that I guess isn't really well controlled by the medicine, or they have very bad side effects from the medicine.
Exactly. Yeah, for people whereby the medication gives a less than adequate treatment response, There are a number of what we call non-pharmacological or non-medicine type of treatments, or meaning surgical treatments. You can either get an injection into that trigeminal nerve, and usually that's a surgeon or an anesthesiologist that will do that. But there's also what we call non-invasive procedures, meaning some techniques where you don't have to go into the body, such as something called a gamma knife treatment.
Right, the gamma knife, in spite of its name, does not use any knives or scalpels or anything.
Exactly. There's nothing where there's nothing that enters the body other than the energy that they actually use in using the gamma knife.
Right. That's what radiation that comes from. I think it's 201 different sources around the head, and it's the point where they all converge, where there's a powerful enough sort of pinpoint of power to, I guess in this case, what would happen to the nerve? Would it destroy that spot in the nerve?
No, actually, so exactly as you said, the gamma knife is almost as though it's a bunch of lasers, but they actually use low-dose radiation. And all of these lasers are focused into one spot, and what you're actually trying to do is target the trigeminal nerve itself. You're not actually trying to destroy the nerve, you're actually just trying to perturb it enough or injure it enough so that it actually settles down and stops causing all of this pain. And it's highly effective, actually, and it works and gives very good responses in most of the cases.
What is the response rate?
At the University of Maryland, I believe our experience has been close to an 80% success rate, and we've done probably over 200 people so far.
With this? Because the gamma knife is also used to treat brain tumors and vascular malformations in the brain and other things as well.
Exactly. So the gamma knife is very versatile in that it can treat a number of different disorders, but it really has been shown to be very helpful for trigeminal neuralgia just because it's relatively safe and easy.
Another painful nerve disorder is shingles. And that's kind of interesting because it's related to chickenpox, right?
Exactly. So shingles, or herpes zoster, is a late life manifestation of something that most kids get, which is chickenpox, meaning that it's the same virus that lives in your body for your whole life and then comes out at a later date. But instead of coming out all over your body, such as with chickenpox, it really comes out just in one single nerve distribution. So it'll be one patch of your body that will be affected with these bumps that you see normally with chickenpox.
So you get a rash.
Exactly.
And I hear it's very painful too.
You get a rash, and you get pain where that rash crops up, meaning that the virus actually lives in the nerves. So when the rash comes back up, the nerves actually get injured by that, and it's very painful. It can be excruciatingly painful, but it is something that it's well recognized, and it really does seem to affect generally older people.
If you had a chickenpox vaccine as a child, will you be protected against getting shingles later in life?
Yeah, that's an interesting question, and actually the studies are being conducted right now, actually looking at adults getting the vaccination to try to see whether the vaccination in adults who may have even had chickenpox in the past is protective against shingles. And that will be if that turns out to be positive, and I don't know the results of these ongoing studies, but that will be very helpful if that is the case, because it's such a problem for those people who do get shingles, I mean, the pain that is.
Is it known why some people will develop shingles?
Usually it's believed that as people get older, as their immune system becomes less robust, that this virus can then represent itself. So really it has to do with aging and probably the loss of a robust immune response. So other people that have, say, cancer and other conditions where they might be getting treatments that affect their immune response, those people are at risk too.
Is there a good treatment for it?
There are a few treatments for the pain associated with shingles. The treatment for the virus itself is actually one of any antiviral agents, which are just, again, some pills that people take to try to actually suppress the virus. For the pain, there are actually a number of treatments people use for the pain, and again, some of the same agents as we talked about before for trigeminal neuralgia. Probably the two that are used most, or that are actually FDA approved at this point, are medications called Neurontin and a lidocaine patch called Lidoderm. So those are probably the most widely used, but a number of other agents are used as well.
We only have a couple of minutes left, but I also wanted to ask you about diabetic neuropathy. And that's where someone has had diabetes for a long time and they start to lose feeling in their feet and their hands. Is that right?
Exactly. Diabetes is a very complex disorder, and one of the problems with diabetes is that you can actually get nerve degeneration or diabetic neuropathy, and that can be very common and also can be very painful and very debilitating because you can lose strength, sensation, and develop pain in your feet and your hands over time with this diabetic neuropathy.
Is the way to prevent that having some really good blood sugar control of your diabetes?
Exactly. There's no bona fide way of absolutely guaranteeing that a person won't develop diabetic neuropathy, but it's clearly been shown that improved control, having tight control of someone's diabetes, will lessen the probability that they will become affected with diabetic neuropathy.
Are there some good treatments once someone starts to have diabetic neuropathy? Are there some things that you can do to slow down the progression of that?
Now, as far as what we call the natural history, again, other than good glucose control, there's nothing that's really going to slow down someone's progression to either develop diabetic neuropathy or prevent it from getting worse. Again, the major focus from in our field is to just control the symptoms, meaning the pain, so that we can give people pain medications specifically for this nerve-type pain, similar to, again, the treatment as we've already discussed with trigeminal neuralgia and the pain associated with shingles.
Is surgery a treatment option for diabetic neuropathy?
Some people talk about surgery for diabetic neuropathy, but other than if you have a nerve compression such as carpal tunnel, I don't think I would ever advocate surgery for diabetic neuropathy.
Do you find that a lot of people suffer in silence over a long period of time, thinking that there's nothing that could be done? And if so, what's your message to them?
I think, especially when it comes to pain, usually people will actually complain or say that they're having pain. If it's just a matter of numbness and weakness, then they probably won't take any action. So more likely than not, people will respond as far as pain goes. But again, anybody that thinks they have a neurological condition that they think needs further attention, again, I would recommend that they see a neurologist and see if there is something that can be done for them.
Thank you very much. My guest has been Dr. Neil Porter. He's a neurologist at the University of Maryland Medical Center and also an assistant professor of neurology at the University of Maryland School of Medicine. If you have any comments or questions about this program, please contact me by email. The address is eblevitt@umm.edu. And if you'd like to reach Dr. Porter or any other University of Maryland physician, call 1-800-492-5538. Or visit the website where you can find a great deal of health information. The address is www.umm.edu. Take good care of yourself. We'll see you next time for Maryland Health Today.